So, today I'm going to go over the anti-inflammatory agents referencing the drug chart, okay? But before we talk about the drug chart and all the drugs and the drug classification, we need to understand the pathophysiology. Obviously, this is covered in depth in your pathophysiology course. I'm just going to talk about some of the major occurrence that happens, especially with respect to tissue injury. Okay, so the goal here is to understand what happens during an inflammatory response, right? What leads up to that inflammatory process? What are the chemical mediators? What are the outcomes? And what are some of the signs and symptoms that we need to watch for? Right? So when there is a tissue injury, you will see inflammation occurs, right? So what is inflammation? It occurs as a result of tissue injury. And this tissue injury, whenever there is a tissue injury, what's going to happen? There is a release of chemical mediators. So there are three chemical mediators, as you can see in this figure, right? We have histamine. We're going to talk about it later too. Kinase, basically these are the bradykinin, and then the prostaglandin. So in this particular chapter, you're going to see a whole lot is focused on prostaglandin. So these are the three chemical mediators. Histamine was one of the first chemical mediator in the inflammatory process. And you will see that pretty much all of them causes that capillary permeability. You'll also see the vasodilation. And then you're going to see prostaglandin, they cause increase in vasodilation, capillary permeability, pain, and fever. So there's a little bit overlap with respect to the drugs that you will see under pain management, okay? But it's good to see at both places. So you kind of remember this. It's like we're not studying in isolation, right? We talk about here and then you see them again and you're like, okay, what's the relationship? So I think this really helps you to see how both are tied in together, okay? So what do you see during an inflammatory process? Release of chemical mediators. What are the chemical mediators? Histamine, kinase, and prostaglandins. As a result of these chemical mediators, what are some of the outcomes? So pain, fever, there is increased capillary permeability, and vasodilation takes place. So then what are some of the signs of it? So you'll see like redness, as you see here, erythema, like. Then you are going to see swelling, as it says here, edema. Pain, so nerve ending nociceptors, right? So there's trigger of nociceptors, and then swelling also you're going to see, and then heat, you see that redness, right? You saw earlier, and with vasodilation you're going to see with fever, heat is different, right? This is occurring in the brain as a result of what? So do you guys remember what causes fever? Probably from your microbiology class. Pyrogens. So pyrogens are substances that induce fever. That's why you will see when you see medication, we'll talk about it down the road, but when you see medications that are used to treat fever, they are classified under the drug class known as antipyretic, okay? So pyrogens are fever-inducing substances. Okay, so that is also, we'll talk a little bit about later how this vasodilation you see here different than when you see it in an inflammatory response, which is vasodilation of the arteries. Okay, so in short, this is what happens during an inflammatory process. So keep this in mind. It'll make much more sense when we talk about it under the anti-inflammatory drugs. But I also want you to keep in mind that inflammation is not always as a result of infection. It may not be. So then you have to think about it. Okay, are there any other causes that can result into inflammation? Think about it. Are there any other causes? Okay, tissue injury is one, but are there any other causes that can lead to tissue injury and it's not due to infection? So that would be like surgical intervention. It could be weather related, extreme cold or extreme hot, right? You could also see patients experiencing trauma, and as a result of it, there is a tissue injury. Caustic chemical agents can also cause tissue injury. So that's something you need to keep in mind. And then when we are talking about anti-inflammatory drugs, we are talking about how do they work, right? So there are different ways, but what's the outcome of that? As a result, they're going to reduce the fluid migration and also the pain. And then sometimes you'll see if this is not taken care and it just progresses, then over a period of time, a person can experience loss of function. Okay, so the whole idea is we want to reduce the pain, we want to reduce the inflammation, and this is in the hopes that we are increasing the patient's comfort and mobility. Okay, so that's the goal. Now, before we talk about the drugs, we also need to understand the function of a very important enzyme known as the COX. COX is known as cyclooxygenase. Okay, so cyclooxygenase is an enzyme. So when we are talking about especially the enzymes, you're going to hear a lot about the enzyme cyclooxygenase. And cyclooxygenase is practically found in all the tissues. Okay, and it helps regulate multiple body processes. So that is something that you need to keep in mind, because that will help you understand why are we using the drugs and then when are we using the drugs. So first and foremost, you will see this chart, right? You see COX-1 and COX-2. So there are many different types of COX enzymes, but our focus is going to be on COX-1 and COX-2. So why are we focusing on the enzyme COX? Because cyclooxygenase is the enzyme that converts the arachidonic acid into prostaglandins. Now do you know why we went and focused on this pathophysiology? Remember here what happens when there is a tissue injury? There is a release of chemical mediators. One of the major chemical mediators is prostaglandin, and prostaglandin can result into all four of this. Okay, so first we need to find out who is synthesizing prostaglandins, and that's why we are talking about cyclooxygenase. So again, cyclooxygenase is an enzyme that converts arachidonic acid into prostaglandin. So before we inhibit this enzyme, we need to understand first the enzyme itself, right? Where is it found? What is its normal function? So cyclooxygenase is practically found in all the tissues, and it helps regulate multiple processes, just I mentioned a little while ago. But we also need to understand what are those processes, right? So you will see that COX-1 and COX-2. COX-1 protects the stomach lining, as you can see here. Let's see. Yes. So COX-1 protects the stomach lining, right? So the mucosa, the gastric mucosa. That's why you might have heard sometimes when patients are on aspirin for a long period of time, what does it result into? Gastric erosion or bleeding. This particular figure explains it very well. Okay, so we're going to first look at what are the functions of COX-1. So you really have to read the question carefully. Is it asking you for function, or is it talking about when you inhibit what happens? So as I said, COX has many different functions because COX is practically found in all tissue. There are two types of COX enzyme, 1 and 2. COX-1 protects the stomach lining, decreases the fever, and it promotes the platelet aggregation. This is the function of COX, right? COX-2, on the other hand, it triggers pain and inflammation. Okay, so if you really think about it, cyclooxygenase COX-2 is also present in the brain. Keep that in mind. Okay, they are found locally, but they are also found in the brain, in the central nervous system. So there is a difference when we are looking at how these medications help treat. Okay, so that is something keep that in mind. So cyclooxygenase is found practically in all tissues, and thereby it mediates the housekeeping chores. Okay, what does that mean? That means it protects the gastric mucosa, it supports the renal function, and it also promotes the platelet aggregation. Okay, COX-2, as we talked about it, COX-2 is basically present in the brain. It mediates the fever, and that's how it contributes to the perception of pain. Okay, it's also found in the kidney, where it supports the renal function. Okay, so these are the function of COX. Now what we need to know is we need to understand, because when prostaglandins are synthesized, it triggers pain and inflammation. So what do we use? We use aspirin or NSAIDs. Now, aspirin also falls under the NSAID category, but I will explain how it is different once we go to the drug chart. Okay. The goal here is to decrease the inflammation and pain, correct? So how can we do that? We are going to inhibit COX-1. So now we are doing the reverse of it, right? First we understood the function of COX. Now we are going to understand what happens when we inhibit COX-1. So when we inhibit COX-1, what's going to happen? COX-1 used to protect the stomach lining. If you inhibit it, what's going to happen? We lose that protection, right? That's why you see a lot of people having issues, gastric issues, if they are on aspirin or NSAID for a long period of time. Okay. Also, since COX-1 promotes platelet aggregation, if you inhibit it, it's going to be reverse, correct? And reverse means now it is going to prevent blood clotting. That's why some people are on NSAID or aspirin especially, right? Because it's blood thinner. We have talked about aspirin. Another function is it's an anticoagulant. This is the reason it's being used, because it prevents platelet aggregation. Okay. COX-2, on the other hand, reduces pain and suppresses inflammation. Okay. So that's why you have selective and non-selective NSAIDs. Selective means it only inhibits COX-2, as you can see in this figure, right? Can you see the COX-2? Let me do this. Sorry. So here you see COX-2, right? These are selective. Keep that in mind. These are selective. And so they only block COX-2. And so if you only block COX-2, all our stomach lining will be protected, platelet aggregation, everything will just be as is, right? The whole goal is it's going to help in reduce pain and inflammation. So then you ask yourself a question, then why do we have the non-selective NSAID? You know why? Because COX-2, it reduces pain and suppresses inflammation. However, it can promote myocardial infarction and stroke. That's why you don't see a whole lot of individuals on COX-2. Okay, so that's the thing. Yes, it decreases pain and inflammation, but it can promote myocardial infarction and stroke. So how does that happen? It is secondary to suppressing vasodilation. Because when it suppresses vasodilation, what's the opposite of vasodilation? Vasoconstriction. Okay, so that's why they say COX-1 is good, COX-2 is bad. Well, that's just the interpretation. Actually, it's just the way it functions, right? So COX-1 has some important functions. COX-2 has some important functions. The problem with the conditions that we are going to talk about, all the musculoskeletal issues like rheumatoid arthritis and osteoarthritis and spondylitis, that's where we want to use only COX-2. But if somebody already has heart condition, this is not a great idea, right? Because it can promote myocardial infarction and stroke secondary to vasodilation. Okay, so this particular figure helps you understand what are the functions of the COX enzyme and then what would happen if we inhibit it. So now we come to the drugs, right? So these particular drug charts helps you understand what are the different drug classes that can help with this condition. right? Because that's the beauty of pharmacology, that there are so many drugs out there in the market, and so we have so many different options depending on what the patient is experiencing and what other conditions the patient is diagnosed of. Okay, so once again, here are the three chemical mediators that you see: histamine, bradykinin, and prostaglandin. So now we are first going to talk about NSAIDs. NSAIDs is the largest drug class that you can see here, right? NSAIDs are used for mild to moderate pain, anti-inflammatory inflammation. You're going to see they are also being used in the treatment of pain, but here we are focusing on inflammation, right? So the conditions that NSAIDs can help is musculoskeletal conditions. Okay, so all these three drug classes, NSAIDs, DMARDs, and corticosteroids. NSAIDs are used to treat mild to moderate, and then DMARDs are used for moderate to severe, and then corticosteroids are used when somebody has an acute attack or a flare-up. So it's like an acute episode that they are experiencing. Now, not that corticosteroids are not good, but there are some limitations. So we'll talk about it in a second, okay? Let's first start with the NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs. They mimic the corticosteroids, but they are different, okay? Because they are not steroids in nature. Now, NSAIDs are classified into non-selective as well as selective. So, first and foremost, understand the difference between non-selective and selective. This is where I've seen sometimes students have a lot more questions, like what is selective and what is non-selective. So the reference here is the COX enzyme. Non-selective, that means it inhibits both COX-1 and COX-2. That's non-selective, right? Selective means only it's going to inhibit COX-2. So now try to recollect the function of the enzyme COX-1 and COX-2. COX-1, as we talked about earlier, what was the function of COX-1? Protects the stomach lining, decreases the fever, and promotes platelet aggregation, right? COX-2, on the other hand, triggers pain and inflammation. So when we are using the non-selective, that means it is going to inhibit both COX-1 as well as COX-2 enzyme. Will that be an issue? In which patients especially would you see an issue? So non-selective means COX-1 and COX-2, right? So if we are inhibiting COX-1, that means we are losing the protection of the stomach lining. That's where it leads to gastric erosion. That's why you see patients experiencing bleeding tendency, right? Because what it does, there is no more platelet aggregation there, right? So that's why it can lead to bleeding tendency. And then it can also cause renal impairment. Now, will it help with pain and inflammation? Absolutely. But there are some side effects that it can result into, right? So keep that in mind. So NSAIDs are divided into two groups, non-selective and selective. Non-selective means COX-1 and COX-2. Selective means it only inhibits COX-2. Now, NSAIDs are also, when we talk about non-selective, they are also classified as first generation, and this selective COX-2 are known as second generation. So don't confuse with the antipsychotics. Remember there also we talked about first generation, second generation, right? Keep them straight. So NSAIDs are classified or categorized into two categories: first generation and second generation. First generation are non-selective. That means they inhibit both COX-1 and COX-2. Second generation are selective and they only inhibit COX-2. Non-selective are commonly used, okay, because they don't pose that risk of myocardial infarction and stroke like the COX-2 does. If you see the first generation non-selective NSAIDs, they are categorized into 6 different categories. For the example purposes, I would like you to remember the salicylate, but after that, remember the drugs to make life a little simple for the exams, but otherwise you should know. It's good to know these drug categories because based on some of the characteristic features, you are able to differentiate, okay? But for the exam, I would say focus on salicylate, okay? That's the drug class that you will see. Okay, now under that you see 6 different groups, and I talk about that in the lecture here. I'm just going to briefly talk about it. Now, when you look at the salicylate, right, earlier on in that chart, that figure, we saw NSAIDs and aspirin, even though they are classified under NSAIDs like salicylate, you still didn't see them together. Why? Here's the major difference, okay? Aspirin selectively, or to be very specific, aspirin irreversibly binds to the COX enzyme. Versus the NSAIDs, they are reversible. That's the main difference. Aspirin binds irreversibly versus other NSAIDs bind reversible. What does that mean? That means irreversible means aspirin will bind to the COX enzyme and the body will have to generate that enzyme. Versus if it's a reversible COX enzyme, that means once the effect is over, the enzyme is still there. So that's the major difference, okay? Now, first generation non-selective NSAIDs, how many groups are there? 6. The one that is most commonly used is aspirin. And people don't realize how great this drug is, okay? Because you get it over the counter too. But always remember, over a long period of time, because, we cannot, if it's a minor inflammation, it's fine. But if it's rheumatoid arthritis, it's an autoimmune disorder, right? So the conditions is going to get worse as it progresses. So that's why aspirin is going to be prescribed for a longer period of time. Then there is that risk of erosion, gastric erosion, okay? So under the salicylate, we have aspirin and we have diflunisal, okay? Then ibuprofen, naproxen, this falls under the propionic acid. Ibuprofen is a highly protein-bound drug, so keep that in mind because then there'll be the drug-drug interaction with other highly protein-bound drug. Then we have diclofenac and ketorolac. Ketorolac is the first injectable NSAID. So sometimes patients are worried of taking other pain medications where there is that risk of potential addiction and abuse. Then this is perfect. It will not result into that dependency. So first injectable NSAIDs. Diclofenac comes in many different forms, and you're also going to see an ointment. You see many athletes, they usually before, let's say someone who is an athlete and plays basketball, before they step their foot on the court, they can just apply that diclofenac and that can really help, okay? And then you have indomethacin. This is used for acute and chronic arthritis, just like you're going to see the Phenemet, meclofenamet, and then you're going to see paroxysm and meloxicam. They are used for long-term arthritic pain. It is also highly protein bound, so that is something that I would like you to keep in mind, okay? Now, indomethacin, as I mentioned here, this drug you will see also for pain, short-term management of pain, you can use indomethacin. So then they have their own unique characteristic features. But these are all first-generation non-selective NSAID. That means they inhibit both COX-1 and COX-2. And then we have COX-2 inhibitor, which is known as selicosib. If you see, the COX itself is in the name, okay? What is the risk of selective COX-2 inhibitor? Yes, it helps decrease pain and inflammation, but it poses a great risk for myocardial infarction and stroke. Then you see Arthrotex. This is the trade name, okay? Now, why this trade name? First of all, you need to know Arthrotec. Okay, so the drug class itself here is here and the use of it. Think about it, patients with RA, rheumatoid arthritis, they are going to take it long term, right? If they are going to take a long term non selective NSAID, there is risk of gastric erosion and bleeding. So in order to protect the stomach lining, what they do is they combine two medications. You can see here, diclofenac, right? You see here, it's the same drug, first generation NSAID, plus misoprostol. So diclofenac is an NSAID, but what is misoprostol? Misoprostol is known as cytotec. That means it protects the stomach lining, the mucus of the stomach lining. Okay, so the patient will not experience or maybe experience very, very minimal gastric erosion or bleeding. Okay, so remember this trade name drug Arthrotec, very important. Arthro means used for arthritic, especially rheumatoid arthritis. And then tech that you see here is basically is protecting the stomach lining. Okay. You will also see sulfasalazine, which is commonly used in the treatment of irritable bowel syndrome. And in this particular drug, you also have to remember it's a derivative of salicylate. So when would you avoid patients or are allergic to what? So sulfasalazine should not be given to patients who are allergic to sulfa. That's why you see here in the name itself, right? Sulfasalazine. So if a patient is allergic to sulfa, then sulfasalazine will not be prescribed to them. Now, because aspirin is so commonly taken by individuals, especially if they have arthritis, it is not like you take it for fever that you are going to take maybe 1 or 2 or 3 days, right? If it's in arthritic condition, obviously they are going to take it for a long period of time. Then what you really need to know is salicylism. And salicylism means toxicity. Okay, so the therapeutic range of aspirin is 15 to 30. Anything greater than 30, it is going to result into mild toxicity. And anything greater than 50 milligram per deciliter is going to cause severe toxicity. So knowing these ranges is going to be helpful. Okay. Then also know, okay, so what are some of the signs and symptoms of salicylate? Tinnitus, ringing in the ear, vertigo, dizziness. Those are some of the things. So let's say you're talking to a patient and during the conversation, the patient says, you know what, I feel great. Like I've been taking this medication, I feel great. But lately I feel like ringing in the ears. That should be a red flag. That means tinnitus, ringing in the ear. Sometimes drug-drug interaction can also lead to tinnitus. So make sure you watch that flip lecture and I give you some examples in that too. Okay. So once again, let's quickly review NSAIDs. NSAIDs are classified into two categories: first generation, non-selective; second generation, selective. Non-selective means it inhibits both COX-1 as well as COX-2. Selective means it only inhibits COX-2. What are the side effects associated with first generation? So since it inhibits both COX-1 and COX-2, renal impairment, gastric erosion, bleeding tendency. With COX-2, helps reducing pain and inflammation, but it increases or poses a risk to those patients who have some heart conditions, especially can result into myocardial infarction and stroke. Arthropod is a combined medication where patients who are given long-term first-generation NSAIDs are at risk of gastric erosion and bleeding tendency. So diclofenac is going to help minimize that pain and inflammation, and misoprostol is going to protect the stomach lining. Okay, then understand salicylism, what is the therapeutic range, and then what would happen with respect to if it goes above the therapeutic range. The second drug class that you see here are known as DMARDs. Now, as I mentioned earlier, these are used in the treatment of RA, rheumatoid arthritis, which is an autoimmune disorder. So DMARD stand for disease modifying anti-rheumatoid drugs. Here you see three different categories: immunosuppressive, immunomodulators, and anti-malarials. Now, you have already heard about azathioprine as well as cyclophosphamide. Let's take a pause and see if you can remember which condition did we cover these two drugs. Do you guys remember? Immunosuppressive, cyclophosphamide, and azathioprine. These two drugs were talked under multiple sclerosis and myasthenia gravis because both of them are also autoimmune. Okay, so immunosuppressive means we are suppressing the immune system. Why? Because autoimmune disorders is when your body, like cellular products, targets your own cell types, right? So that's why these drugs are used to suppress the immune system so they do not cause that reaction. Immunomodulators, on the other hand, it changes how, or it modulates the immune system, the manner in which it reacts. Okay, so it changes that process. Okay, so those are immunomodulators. And then we have antimalarials, which we don't know the exact mechanism of action of antimalarials. However, antimalarials are also used in the treatment when all the other treatments fail. But know that all these medications take a longer time to start seeing the effect. So like antimalarials can take anywhere between 4 to up to 12 weeks. Okay. These drugs are more toxic. So what do we mean by more toxic? Yes, it helps with the condition, but since they work in a way that immune system protects you, that's where we say they are more toxic because there are some side effects associated with it. So as we talked earlier, NSAIDs help with mild to moderate, DMARDs help with moderate to severe inflammation. So that's why when NSAIDs cannot control, then DMARDs are given, or if the condition has progressed. Okay, so what are some of the conditions you can see DMARDs being used? Rheumatoid arthritis, osteoarthritis, severe psoriasis, ankylosing spondylitis, ulcerative colitis. Okay. Immunomodulators are further subcategorized into two categories, okay? And these are interleukin-1 and then tumor necrosis factor, okay? So these are the two subcategories under immunomodulators. Also know that these are given parenterally. These are very expensive. Like, we talk about other drugs, they cost thousands of dollars. So again, it is very carefully thought about before the candidate can be given, is a potential candidate. The patient is a potential candidate for this medication. Okay, so that's something that I would like you guys to keep in mind. And then some of these medications warrant keeping track of the BUN, the ALT, the AST, the liver enzymes. Okay, so that is something I want you to keep in mind. Also know that the second one, where is it? Okay, so you have immunosuppressant, immunomodulators, antimalarials. Okay, I want to talk a little bit about methotrexate. Methotrexate is an immunosuppressive. So whether it's an immunosuppressive or immunomodulator, one thing you need to keep in mind is because it's suppressing the immune system, the patient is at risk for infection. Okay, so if they have fever or sore throat, then we need to educate them to call the doctor's office because their immune system is down, right? So they are more prone to infections. Now, methotrexate, many of you might know, might not know, is also used in the treatment of cancer. So sometimes patients, when they hear the term methotrexate, they're like, why am I given methotrexate? I have only rheumatoid arthritis. I don't have cancer. Why am I given this medication? So for that reason, you will see that the one that is used for rheumatoid arthritis, the trade name is Rheumatrax. But since you as nursing students needs to know the generic names. Keep methotrexate in mind that yes, it is used in the treatment of cancer, but it is also used for rheumatoid arthritis. It can delay that progression. One of the important patient teaching is you'll see that also their liver enzymes will be monitored. So before they start the baseline and then over a period of time. That brings us to corticosteroids. Okay. Now, corticosteroids are usually used for flare-ups. Why? Because as you would have learned in patho that they have many side effects. Okay, now these are injections, right? So they are not given for a long period of time. But if oral is given, which is not usually for a long period of time, is they have many side effects. One of them you probably know is weight gain. But the other important is it also suppresses your immune system. So that's why over a period of time. So it's only used for short term and it is given as a injection. It helps it really is very helpful to those patients who are experiencing flare-ups. Okay. Last but not least, we talk about gout. And you probably know earlier it was known that gout is a disease of rich people because alcohol used to cause that. So gout is an anti-inflammatory condition of the joints, the tendons, and the tissues. When you see there is excess or high levels of uric acid in the blood, so men usually 7 milligrams per deciliter and above, and female is above 6 milligram per deciliter. So high levels, hyperuricemia, high levels of uric acid in the blood, okay? You will see it is also referred to as gouty arthritis. Big toe is the common site, but that doesn't mean that it cannot occur anywhere else. Okay, so that is, know that. As I mentioned, is due to high levels of uric acid, so characterized by uric acid metabolism, a defect in purine metabolism. So always remember the food, which are the foods that are high in purine. So like salmon or organ meat or sardines or legumes. These are all, results into that high amount of purine can result into uric acid. So the cause, okay? Now, the drugs that are used in the treatment of gout, you have anti-inflammatory, so colchicine inhibits the migration of leukocytes. Remember, we want to limit that. We want to localize it. So that's why you don't have it everywhere else. Usually, you'll also see colchicine used for flare-ups, acute episode. Uric acid biosynthesis inhibitor. So this is important. Like, how would you remember? There are always so many drug classes. So here's one way to think about it. Okay, what is the pathophysiology? It is due to defect in purine metabolism, right? So it ends into high levels of uric acid. So uric acid is the issue, right? We don't want too much amount of uric acid. Why? Because then you can get accumulation of urate crystals, and these crystals can deposit into the kidney, and then it can cause damage to the kidney. So there are implications of high levels of uric acid. So there are 3 different drug classes. You have colchicine, which is it inhibits the migration of leukocytes, and that's what causes the inflammatory acute attack of gout, episode of gout. So used for flare-ups. Now, can we increase the acceleration of uric acid out of the body? 1. And 2, can we inhibit the synthesis of uric acid? So if there's too much uric acid, we want to inhibit the synthesis, right? Think it that way. Cause is high levels of uric acid. We can, if the uric acid is already formed, then what do we want to do? Accelerate and excrete it out of the body. Or we don't want uric acid to be formed, right? So there's 2 things we can do. Either we can inhibit the final steps of uric acid synthesis. That's why you are seeing it called as uric acid biosynthesis inhibitors, right? It is also known as xanthine oxidase inhibitor. So you are inhibiting the enzyme that will then result in the synthesis of uric acid. Okay, so that is allopurinol and flebucetate. Now, allopurinol has been out there for many, many years, okay? And of course, it's not as expensive. So that's why you will see allopurinol commonly used. And then uricosurics belong to the drug class accelerated excretion of uric acid. That means if uric acid is already formed, you can't stop it from formation because it's already formed, right? So we want to excrete out. So think about it. If it's already formed, that's when you're going to give. And then allopurinol is used preventive. So you can prevent the formation of uric acid, okay? So these are the three drug class under the anti-gout. One, inhibit the migration of leukocyte, which is colchicine. Then allopurinol, which falls under the uric acid biosynthesis inhibitor. And then you have probenecid, which belongs to the drug class uricosuric. Okay, so anti-inflammatory agents are divided into 4 different drug classification. The first 3 you're going to see especially for rheumatoid arthritis, osteoarthritis, ankylosing ulcerative colitis, all different inflammatory conditions. Osteoarthritis too, I think I mentioned, right? NSAIDs are divided into first generation, second generation, first generation non-selective, second generation selective. DMARDs are disease-modifying anti-rheumatoid drugs. These are given to patients who have moderate to severe inflammatory condition, and they are immunosuppressive, immunomodulator, anti-malarials. And then corticosteroids are used for flare-ups. And then anti-gout. This is specifically used for gouty arthritic condition. It is as a result of defective purine metabolism, and then it is divided into 3 different classes. And that completes the anti-inflammatory agents. Hopefully you find this explanation helpful.